Hi again, folks. Welcome to the next lecture. This is on TBI and children and adolescents. So first, some demographics. About 500,000 children and adolescents in the United States visit the emergency department with brain injuries each year. So boys from 0 to 4 and from 15 to 19 years of age are at the highest risk for traumatic brain injury. And the causes include falls, motor vehicle accidents, what's referred to as shaken baby syndrome, and sports and play-related injuries. Most traumatic brain injuries in children are mild, that is, they're concussions. Concussion sign and symptoms include headaches, nausea, vomiting, slurred speech, confusion, depression, slowed thinking, and a concussion can have negative effects on learning and cognition. So a little bit about mechanisms of TBI in children. Children are not just little adults. So there are differences in brain anatomy, cerebrovascular response to injury. So for example, autoregulation of cerebral blood flow and perfusion pressure. Injury effects on cell signaling are different. Biomarkers of cell damage are different, and the risk of complications are different between children and adults. Younger children are more likely to have diffuse cerebral edema than focal contusions. Older adolescents, however, are more likely to show diffuse axonal injury and focal contusions somewhat similar to adults. Now, shaken baby syndrome, this is non-accidental inflicted injury, is the leading cause of child maltreatment death in the United States. Clinical signs and symptoms include retinal hemorrhages, subdural or subarachnoid hemorrhage with little to no evidence of external head trauma, and possibly brainstem injuries as well. These injuries occur in response to violent, rapid acceleration and deceleration of the head, combined with angular and rotational injuries as the infant's proportionally large head whips back and forth without strong neck support. Shaken baby syndrome is associated with more severe injury, prolonged unconsciousness, higher hypoxic ischemic injury incidence, so secondary factors, and worse short-term cognitive outcomes than accidental injuries. Children with moderate to severe TBI show smaller overall brain volume versus peers, as well as gray and white matter changes, for example, reduced white matter integrity, due to focal lesions and diffuse axonal injury. Changes in brain function can be present even in absence of observable structural changes. That is, the imaging detects no evidence of structural damage in mild TBI. Unfortunately, there are research limitations with many of these studies studying moderate to severe traumatic brain injury in children. Studies of children and adolescents with TBI often exclude subjects with language-based learning disabilities due to complex interactions that occur between the pre-existing disability and the injury. Boys and girls can be grouped together in these studies, which obscures sex-based differences in cognitive development. And underrepresentation of low SES and non-native English speakers is also evident in these studies. So regarding recovery, the strongest predictors of cognitive communication outcomes are initial injury severity, extent, location, pre-injury IQ, and adaptive behaviors. Physical recovery oftentimes occurs faster than cognitive communication recovery. Unique features of childhood TBI recovery include that the recovery occurs in the context of development. The child is still developing cognitively, linguistically, socially during the period in which the acute incident occurs. So the TBI can have significant negative effects on continued development of brain structures and functions. So for example, cognitive communication functions may improve at a slower rate in these individuals, or they might stall compared to peers. And this might happen for years after the injury. The prefrontal cortex may also be less plastic than other regions, which might result in significant executive function deficits in these individuals. The nature and extent of recovery from TBI depend in part on age or the stage of development at injury. Injuries sustained earlier in development are associated with worse long-term cognitive communication outcomes. The nature and extent of recovery are also influenced by the child's environment. So the response of the patient's family will influence the outcome. So things such as making decisions as a family, feeling supported or accepted, confiding in each other, feeling able to express emotions are associated with better outcomes. Having two parents is also associated with better outcomes. So if one has two parents, practical issues such as finding adequate transportation to appointments are easier. Carryover of therapy activities might be easier, and managing work versus home responsibilities might also be easier in a two-parent household. The child's environment also seems to be a bit more important for younger kids versus older kids. So children that have suffered a traumatic brain injury usually have formal aspects of language that are relatively intact. So things like phonology, syntax, morphology, semantics, these may be relatively intact, but pragmatic aspects are oftentimes significantly impaired. Traumatic brain injury in children also often results in working memory deficits, and these deficits continue to improve during the second year status post-injury and mild to mod TBI versus no change or even a bit of a decline in severe TBI. Executive function deficits are also apparent. And there's some conflicting results in the literature. And the literature has variable task selection and inclusion criteria for the various research studies. So that might be why there's conflicting results. The literature indicates that deficits in inhibitory control, cognitive flexibility, and goal setting might occur, and also lower scores on the Behavioral Rating Index of Executive Function, or the BRIEF, are also observed in children with traumatic brain injuries. Attention deficits are also apparent, although there are conflicting results regarding severity in the literature. There appear to be deficits in divided, focused, and sustained attention in some studies. However, other studies have found that that focused attention appears to be relatively spared. So social cognition deficits are the set of cognitive skills required for an individual to successfully interact with a social group. So these include skills such as theory of mind and emotional recognition. Theory of mind is the capacity to understand other people by ascribing mental states to them. So being able to surmise what's happening in another person's mind. That's theory of mind. Social cognition appears to be mediated by neural networks that include frontal lobes, amygdala, insula, and the connecting white matter tracts between these regions. And this appears to be vulnerable in children with TBI due to the commonality of frontal lobe damage and the extended developmental path of the frontal lobe, and changes in the myelin sheath that occur during adolescence. Research also indicates that procedural learning and memory of pre-injury information are often spared in these individuals. Children with severe TBIs may have smaller vocabularies and lower IQs than typically developing children, and this gap may increase over time after injury. So not only is the initial trauma causing loss of function, but there is a gap that occurs between these individuals and their peers due to an impairment of learning processes that might result in a slower learning rate and perhaps worse retention of information. As I mentioned before, many formal aspects of language, such as syntax and semantics, might be spared. There is some evidence of reduced syntax compared to typically developing peers in some studies, but these deficits may be subclinical, that is, within normal limits. Other studies, however, show that syntax and vocabulary are relatively spared in these individuals. So there is a discrepancy depending on what study you're looking at. Primary deficits in children with traumatic brain injuries may be primarily pragmatic. Pragmatic deficits in children with traumatic brain injuries include reduced comprehension of indirect language, sarcasm, humor, metaphors, implied meanings, proverbs, deception. They're unable to identify violations of social conventions, such as bragging. Discourse analysis indicates that children after a traumatic brain injury may perform similarly to typically developing peers in certain areas, such as cohesion, coherence, turn taking. However, there is lots of variability in these. There is lots of variability across subjects with a traumatic brain injury. As I mentioned before in the adult section, TBI is a heterogeneous population. So just like adults are highly variable that have suffered a TBI, children that have suffered a TBI are similarly heterogeneous. Deficits that have been observed in children with traumatic brain injury following discourse analysis include things such as topic maintenance deficits, discourse organization deficits, and narrative summary skills deficits. Children with traumatic brain injuries are a heterogeneous group. When you are assessing a child with a traumatic brain injury, you always have to consider the child's age or stage of recovery, their level of premorbid functioning, and the purpose of the assessment when you're selecting assessment tools. Note that standardized tests that were designed for children and adolescents with traumatic brain injury are very limited. And scores from tests not designed for these populations should be interpreted with caution and in the context of additional information. Informal assessments are highly useful. These provide important information for identifying deficits in functional settings and characterizing activity and participation limitations. Collaboration between team members is essential. This helps promote better coordination and quality of care for children and adolescents with traumatic brain injury. There is a pediatric version of the Glasgow Coma Scale. There's actually a few of them. The book recommends the Child's Glasgow Coma Scale, the CGCS. You should note when attempting to administer any kind of standardized assessment, the child in question may not have mastered the ability to follow verbal and or motor commands, depending on what developmental stage that they're in. Following a traumatic brain injury, the patient will often emerge from the coma, regain consciousness. They may transition to a vegetative or minimally conscious state, and then a post-traumatic amnesia period characterized by disorientation and confusion. Now, vegetative state is clinically defined as a condition of complete unawareness of the self or of the environment, with intact sleep-wake cycles and at least partial functioning of hypothalamic and brainstem autonomic functions. Minimally conscious state, however, is slightly different from vegetative state. Individuals in the MCS stage, they demonstrate evidence of limited but definite awareness of the self or environment. And they may be able to perform meaningful behavior such as following commands. And this can be inconsistent, but it should be sustained and repeatable. A primary goal in the early stages of assessment within the acute period is to monitor for signs of the emergence of consciousness, such as functional communication or object use, taking into account the child's immature language and motor systems. The timeline of emergence from the post-traumatic amnesia stage is an indicator of injury severity, with longer PTA periods being associated with worse outcomes. Once the child emerges from the PTA stage, focus then shifts to assessing and treating cognitive communication, identifying target areas for intervention. Assessment for children with TBI in the post-traumatic amnesia or subacute recovery stage. These include assessments such as the Children's Orientation and Amnesia Test, the COAT, and the Functional Independence Measure for Children, the WIFIM. So the COAT is designed to evaluate children and adolescents with TBI between the ages of 3 and 15. The WIFIM assesses child's independence in a variety of domains, including mobility, self-care, language, social interaction, memory, and problem solving. It is also useful for tracking progress in activities of daily living and communication skills. And it has been validated for evaluating functional outcomes in children with TBI. Assessment must always consider the ICF framework. So body structures and functions, activity limitations, and participation limitations. You will want to assess both aspects of formal language, such as vocabulary knowledge, word finding, syntax, comprehension and production, comprehension of age-appropriate verbal information, figurative language, inferencing, social language, and underlying cognitive skills, such as attention, memory, executive function, and social cognition. Standardized assessments may be used once the child is in a later recovery stage. So assessments such as the Test of Language Competence Extended, the TLCE, the Behavior Rating Inventory of Executive Function, or the BRIEF. And one should note that standardized tests designed to measure developmental language problems will likely not be sensitive to deficits in children with traumatic brain injury. However, if deficits are apparent, cognitive deficits might be contributing to the reduced performance on various language tasks. I should mention that the TLCE and the BRIEF have met established validity and reliability criteria, so these are good assessments to use for these populations. I should also mention that research on a few different language tests, the TOAL-3 and the CELF-3, the SELF-3, suggests that underlying cognitive impairments influenced subject test performance. Subjects post-TBI performed better when working memory demand was reduced. Subjects that had a language disorder without a TBI performed the same. So cognitive impairments seem to be influencing subjects' performance on a few of these language tests. It should be noted that these tests did not aid in detection of TBI-related deficits, though. Other standardized assessments may be appropriate for this population. So the Test of Integrated Language and Literacy Skills, the TILS, could be appropriate for school-age children with post-TBI. The Pediatric Test of Brain Injury is a criterion cognitive communication assessment that identifies deficits via various functional tasks. It includes things such as personal information, like orientation, and then also higher level information such as story retelling. Also, the Functional Assessment of Verbal Reasoning and Executive Strategies, student version. This assesses language-based executive function skills and tasks mimicking real-world activities, so it might be a little bit more ecological. There are some recommendations from the Pediatric TBI Outcomes Work Group. So these are assessment outcome recommendations, and I provided a link here. Also note that standard scores and standardized assessments can over or underestimate the skills of a child with a TBI. And age equivalent scores are rarely appropriate, so you must interpret these scores with caution if you decide to use them. Environmental and situational variables in real-life activities often have cumulative cognitive demands that cause greater deficits in function than may be predicted based on standardized scores. Therefore, we should use informal testing as well to supplement standardized testing. As school is a crucial functional setting, perhaps assessment within the classroom context would be appropriate. It would also be appropriate to assess limitations in the child's activities, their participation, environmental limitations, and personal factors that might be influencing cognitive communication. Discourse analysis can be used in children with traumatic brain injury, as with adults. One good thing about discourse analysis is the concept of hypothesis testing, which was discussed earlier, which is useful for identifying cognitive, linguistic, and environmental factors influencing performance. It's also useful for goal planning and identifying optimal contextual supports. Informal assessment can be used for assessing and remediating social cognition deficits, things such as facial emotion identification and observation of peer interactions for analysis. You can also use subtests from standardized assessments, such as the subtest for making inferences in the SELF-5 or the pragmatic judgments subtest of the CASTLE, which may be useful for assessing social cognition. So regarding intervention of children with traumatic brain injuries, there are pediatric specialty programs that exist in certain medical settings, and these are more than just age-down versions of adult rehabilitation programs. There are 8 critical components of a family-centered pediatric specialty program, which are listed here. Programs must be interdisciplinary, collaborative, individualized, and take the child's age and developmental stage into account. Care should be developmentally appropriate and take into account a child's need to learn and to play. It is important to collaborate with and educate various school liaisons, such as teachers and principals and various administrators, regarding how care of the traumatic brain injury patient differs from care for other disorders. such as intellectual disability and specific language impairment. Intervention in acute care. So children with mild TBIs, oftentimes these are sports-related injuries, may not be admitted to hospitals. Many families don't seek medical attention. They just think that, oh, he'll be fine, sort of a thing. If they do seek medical assistance, they might be given monitoring guidelines. Well, come back if this happens, if you observe these signs and symptoms. And so the family might follow up just on an as-needed basis. There is a link here for the Injury Center of the CDC that has some valuable information. I encourage you to check that out. The intervention goal for children with moderate to severe traumatic brain injuries is primarily prevention of secondary damage. And the SLP's focus in acute care is largely assessment-based. So you're going to be doing in acute care a lot of assessment and not as much treatment. The focus will be on feeding and swallowing assessment, establishing the appropriate diet level and swallow safety, and establishing a reliable communication system. Once the patient is medically stable, the patient is then transferred to in or outpatient rehab. Now, regarding criteria for determining readiness for discharge to inpatient rehab, this varies by facility. Some accept minimally conscious state patients or vegetative state patients, and some do not, and it's exclusively outpatient even. So sites vary. Some facilities might require the patient to not be trached or vented, and they might require no feeding tubes. In order to discharge to inpatient rehab, generally speaking, the patient should have evidence of meaningful interaction with their environment, be able to tolerate 3 hours of therapy a day, and require 2 or more therapy types, so OT, PT, or speech. The length of stay in inpatient rehab depends on the patient, and the patient may be discharged if there's no medical reason to remain inpatient. Regarding intervention in post-acute care settings, you have to consider personal factors, as always. So basically, their prior level of function, pre-injury knowledge and skills, academic language skills, premorbid conditions, and motivation, too, is a very important factor. There are 2 basic models regarding intervention in post-acute care settings. So the social disability model and the medical or developmental model for pediatric rehab. The medical model is an older model that focuses on rehabilitation of impairments. So example goals using the medical development model include comprehension of metaphors, idioms, implied meanings, so various aspects of executive function and social cognition. The social disability model is different, and it's supplanting the medical model a little bit nowadays. In this model, the patient is central in decision-making about the intervention. The patient's environmental supports, personal preferences, and beliefs are considered explicitly in treatment planning. So it's more patient-centered care. And in this model, the therapist shares responsibility for improving life beyond the clinic. Goals for the social disability model might include such things as teaching verbal scripts to facilitate conversation with peers, or to ask for homework clarification in class. This perhaps might be more motivating to this patient. Group therapy is oftentimes used as well, which includes training of social skills in more naturalistic environments. One should always ask, how will this goal facilitate the patient's life participation? This is a very important question. The goal should be meaningful to the patient and to the payer, meaning the insurance companies. So you have to consider how you word your goals in order to justify payment to the insurance companies. Social language will probably be a high priority for these patients. In this post-acute care stage, education of family and caregivers, school teachers and administrators, school peers, and employers, if it's an older patient that has a job, is going to be very important. In order to ease the transition back into the school and vocational settings, to facilitate the plan of care and aid in carryover and in generalization. Brain injury in children affects their learning and acquisition of new skills and can particularly limit development of higher level cognitive communication skills even years after the injury. The goal of intervention in the acute phase is to prevent further damage due to medical complication. So medical intervention performed by the doctors and the nurses, and we act in basically a monitoring role. We act in basically a monitoring role at the beginning, and then a kind of combined assessment treatment role once the patient regains consciousness and starts to progress through the various stages of increasing awareness and function. Intervention goals in the post-acute phase focus on improving life participation and successful reintegration into school and other daily life events. Guidelines for intervention following TBI are evolving. There is currently somewhat limited research evidence regarding traumatic brain injury in children. However, a few things can be stated. Attention deficit should be addressed. Family members should be involved as active treatment providers, and parents and guardians benefit from education. There is a link here to an article, Systematic Review and Quality Analysis of Pediatric Traumatic Brain Injury Clinical Practice Guidelines. That is of note, and I encourage you to look at that. So partnership between the family and school or rehabilitation therapists is crucial. The goal of pediatric intervention is interdependence between children and families, not independence, which is the goal for adults. Collaboration between the medical team and the school team can be a key in a successful transition. That's it for this video. Thank you very much, and I'll see you in the next one.